Welcome and thank you for joining tonight's session, which is part of the Childhood Addiction series. Tonight's topic is identifying and assessing eating disorders in children and adolescents. My name is Dana Harris from the PHN Education team, and I'll be facilitating tonight's session. I'd like to start by acknowledging the traditional custodians of the land we are meeting on today and pay respects to elders past, present, and emerging. Before I introduce our speakers for this evening, I have a few things I'd like to let you know. As attendees, your camera is automatically disabled and your microphone will automatically be muted. If you have any questions or would like to make any comments during tonight's presentation, please send these through the question box and these will be answered at the end of this evening's presentation. An evaluation will come directly to you after the session this evening. We would be very grateful if you would complete this, as the information is very important for us to ensure these sessions meet your needs and expectations. Lastly, participants in this webinar will be able to register for a live interactive peer support Echo Hub, which is a case-based discussion on identifying and assessing eating disorders in children and adolescents. This is planned for Wednesday, the 26th of October at 7 p.m. During the session, you'll be required to use active thinking skills and form professional opinions on the case conference presented. After tonight, you will receive an automatic email with the information for registration on this session. It is now my great pleasure to introduce our speakers for this evening. Dr. Julie Adamson is a general practitioner and adolescent physician at John Hunter Children's Hospital and is current head of the general pediatric team. She has worked with young people who have eating disorders for over 20 years and is the medical lead for inpatient care of young people with eating disorders at John Hunter Children's Hospital. Deanne Harris is an advanced accredited practicing dietitian, senior dietitian, and professional lead for the Hunter New England LHD. She has over 30 years clinical experience as a rural practitioner based in Tamworth, New South Wales. She has worked as a dietitian for those living with eating disorders in both the hospital and community-based clinics such as Headspace during this time. And Gemma Olson is a second-year clinical psychologist registrar working in the northern areas of Hunter New England LHD. She is currently working in a newly established eating disorders clinical support team, providing support and consultation to clinicians across the LHD, working with children, adolescents, and adults with eating disorders in inpatient, outpatient, and community settings. She also continues work with Peel Health, adolescent mental health services, providing psychological treatment for young people and families where there are acute and complex mental health difficulties. Thank you for being with us tonight, Dr. Adamson, Deanne, and Gemma. I'll hand it over to you, Julie, for tonight's presentation. Yep, we can see your screen. Thanks, Julie.
Excellent. I just need to get rid of you guys. Thanks very much, Dana. So I'm going to talk this evening on identifying and assessing eating disorders in children and adolescents, and Dana's introduced our panel. I would also like to acknowledge the original custodians of this land and pay respects to the elders, both past, present and future, for they hold the memories, the traditions and the culture and hopes of Aboriginal Australia. I'd like to start by just identifying, I'm just trying to change my screen so I can read the slides myself. This is a informational page from the National Eating Disorders Collaboration, which is one of the resources that I'll mention at the end of the talk that is quite useful for information about eating disorders. It talks a little bit, these are their sort of 7 main facts that they want to get across in a summary slide for people about eating disorders. The fact that they're common, approximately 1 million Australians are living with an eating disorder in any given year, that they're serious and complex illnesses, accompanied by both physical and mental health difficulties, that they are more prevalent amongst adolescents and young peoples. So the average onset of eating disorders is between 12 and 25. So they can happen at any stage of life, but that's one of the main peaks of presentation. The factors that contribute to developing an eating disorder differ from person to person. So they're known to be multifactorial and involve biological, psychological and sociocultural factors. And that many people diagnosed with an eating disorder don't access care. Only about 23% access appropriate treatment. So there's lots of room to improve access to care and identification of people with eating disorders. And the challenges include things like stigma, ambivalence about recovery, cost of services, limited availability, and difficulty recognising that there is an eating disorder or the severity of the eating disorder. Eating disorders can co-occur with other mental health problems, so it's important to think about them. In many people that you see with depression, anxiety and other medical conditions also increase the chance of having eating disorders, especially things like diabetes, which is increasingly being recognised as a risk factor, and obviously gastrointestinal illnesses too that have a big focus on food. It's possible to recover from an eating disorder even if the person's been living with the illness for many years. So much of what we'll talk about today is adolescence and early onset of eating disorder and trying to detect people in the early phase of their illness to improve their prognosis, but even people who are severely affected can recover. Oops, why is it not progressing? Okay, sorry about that. So what are eating disorders? They're common, they're serious, they're scary for everyone involved. So lots of people feel underprepared to manage eating disorders. They're often challenging to understand. So lots of things about considering eating disorders are somewhat counterintuitive. They are difficult to treat and they're expensive and labour intensive for health services. They're really important and they're often quoted as being the mental health disorder that has the highest mortality rate, and that is up to 20% after 20 years of illness. The mortality rate is 5 times higher than the general population matched for age. The death from natural causes is quoted as 4 times higher, and death from unnatural causes 11 times higher, and death from suicide an alarming 32 times higher than expected, and that's 20 times the death rate from major depression. So the major causes of mortality are almost equally split between physical causes for death and suicide. And I guess I've added some of these slides which come from postcards that were produced back in 2014 and really to remind us that body image is very prevalent in our society and probably affects most of us. I'm going to talk a little bit about diagnosis of eating disorders, and obviously the main diagnostic criteria that we use are outlined in DSM-5, and the eating disorder categories listed are anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, often known as ARFID, pica, rumination disorder, and then OSFED and UFED, which are the new categories in DSM-5 that describe either unspecified or sub-threshold diagnoses of the other disorders. My particular interest and what I work mostly in is managing young people with anorexia nervosa. I see some people with bulimia and increasingly patients with ARFID. I don't have much experience with binge eating disorder, and pica and rumination disorder don't often come to light in hospital inpatients or my clinics, so I have less experience with them and I'm not going to address those today. But I will go over the criteria for some of the others. So anorexia is a persistent restriction of energy intake leading to significantly low body weight. And so the criteria include that, plus either intense fear of gaining weight or of becoming fat, or persistent behaviour that interferes with weight gain, even though at a low body weight, and then disturbance in the way one's body weight or shape is experienced. undue influence of body shape or weight on self-evaluation, or the persistent lack of recognition of the seriousness of the current low body weight. And some of these things aren't as easy to detect or recognise as they might seem. There are two subtypes, restricting type and the binge purging type. And I guess this is just to reflect that this slide is used frequently. I think it's showing that, you know, young people with eating disorder have a misperception of their own body image, and that's often really hard to understand. They don't see themselves as we do. I've put in a few BMI charts. So this is typically what I might see in a young person presenting with anorexia nervosa. This particular person, I'm not sure if you can see my cursor, but there's been a rapid weight loss. So this was a 15-year-old girl who presented with about a 12 kilo weight loss over the past 6 months, about half of that in the month before presentation. So a very rapid weight loss. And then in therapy, she has gradually improved her weight and got her BMI up to around the 50th percentile. But as often happens, as she's moved into year 11 or 12, she's struggled again and is really managing to keep her weight at the moment just at a weight that is barely sufficient for health and not able to provide enough energy or fat to allow menstruation. The next I wanted to talk about was atypical anorexia nervosa, which comes under the OSFED other specified feeding and eating disorders. So it's a sub-threshold anorexia. So it meets all of the criteria for anorexia nervosa, except that despite significant weight loss, the individual's weight is within or above the normal range. And I think probably at least 20% or so of our patients would fit this criteria now. And often they're recognised, or they're slower to be recognised because the young person may not be underweight but still have a significant problem. So this is what a weight chart might look like, or a BMI chart. And I'm showing you charts because I trade in charts day in, day out. Part of my role is plotting weights and heights and looking at BMI charts, and they're not perfect, and we can discuss that later. There's lots of arguments about the value of them, but they're a useful tool in trying to see what's happening over time for young people. So I'd certainly encourage everybody to chart, not only measure, but chart weights and heights and BMIs. So this is a graph from a young person who had type 1 diabetes, who had been above a healthy BMI range. Up above 85 is classed as above a healthy range, and had lost a significant amount of weight quickly and then has hovered and now has stabilised within a healthy range. I'll talk a little bit about bulimia nervosa and the diagnostic criteria for that. So it involves recurrent episodes of binge eating, and binging is described as eating in a discrete period of time an amount of food that is definitely larger than most people would eat during a similar period, and also having a sense of lack of control over eating during the episode. I think this is sometimes tricky because many young people with eating anorexia will tell you that they've binged, but their description of a binge would be eating a normal meal or catching up for one meal that they've missed at the same time, and that wouldn't necessarily qualify as abnormal amount of eating. So this is definitely an abnormally large meal and a sense of lack of control, and then is accompanied by recurrent inappropriate compensatory behaviours such as vomiting, misuse of medications, including things like insulin, fasting or excessive exercise. And then binge eating and inappropriate compensatory behaviours both occur on average at least once a week for 3 months. So it's over a 3-month period. It's not something that happens just for a week. And that their self-evaluation is unduly influenced by body shape and weight. And there is an exclusion criteria to say this does not occur exclusively during episodes of anorexia nervosa. So if it is deemed that there is binging as part of the anorexia nervosa, it would be classed as anorexia nervosa binge purge type. Binge eating disorder, which is the one I'll describe that I have the least experience with, but it is there's increasing interest in helping young people and people throughout the lifespan with difficulties with binge eating. So it's described as recurrent episodes of binging. The binging episodes are associated with three or more of the following: eating more rapidly than normal, eating until uncomfortably full, eating large amounts of food when they're not physically hungry, eating alone because of feeling embarrassed by the volume one is eating, feeling disgusted with oneself, depressed or very guilty afterwards, and that there's marked distress regarding binge eating. And the binge eating occurs again on average once a week for 3 months, and that it's not associated with compensatory behaviours and does not occur exclusively in the course of anorexia or bulimia. So I guess the main difference with binge eating disorder is that there's not compensatory behaviours, and that generally will lead to people being above a healthy weight range. And then ARFID, which we're seeing increasingly in our hospital inpatient and outpatient range, and I guess has been a new addition to the DSM-5. So we're really still gathering information and evidence about management of ARFID. It's been recognised for a really long time, and in future we'll probably end up with a number of subcategories, but at the moment it's described as an eating or feeding disturbance manifest by persistent failure to meet nutritional needs associated with at least one of the following: significant weight loss or failure to achieve expected weight gain. And so that's also really important in children, is to note not only, so it's not just weight loss we're looking for, it's actually the failure to grow, that there can be significant nutritional deficiency, that there's dependence on enteral feeds or oral nutritional supplements. So these are young people who aren't able to eat sufficiently to maintain their own health and can become dependent on other forms of feeding. And that there's marked interference with psychosocial functioning. The behaviour is not better explained by a lack of available food or by an associated culturally sanctioned practice. So it's not, so it doesn't include, or there would be exclusion of people who are not provided by food for psychosocial reasons. And there is no evidence of a disturbance in the way one's body weight or shape experience. So these young people often know they're really underweight and want help, though they find it very difficult to eat. And that the eating disturbance is not attributed to a medical condition or better explained by another mental health disorder. So this is a weight graph or body mass index graph of a young person with ARFID that we're currently looking after. As you can see, this young man, so again, this is more equally divided across the sexes, was underweight and failing to grow for quite a long time before he came to attention, and then has had a number of episodes of refeeding. Each of these peaks has involved active refeeding in hospital, and he's continuing to struggle to eat sufficiently, though arguably maintaining a better BMI, and has had some height growth catch up since he was better nourished. So what am I interested in on history when I'm talking to these young people or meeting someone that's been referred or where the issue of concern for eating disorder has been raised? I'm really interested in the growth and weight history. So it's important to know where they've been before, what's been happening recently, and how things are changing. And it's really very helpful to have height and weight measures and BMI measures and have them charted. I'm always delighted when my endocrine colleagues refer me patients, not that I want patients that are unwell, and often they send me quite complicated patients, but nobody charts weight and heights nearly as well as endocrinologists, and so they often come with a really long, good history of what's been happening. And many young teenagers don't have height or weight measures done through childhood if they've been otherwise well, but it's important if the issue is raised to start measuring and charting from the moment the issues come up. I'm also interested in medical symptoms, which are signs of nutritional inadequacy and signs of medical compromise. They're often cold and blue, so as their nutrition their energy intake becomes inadequate, the cardiovascular system shuts down peripheral circulation, their heart rate slows, so they become cold, they become cold intolerant, they often have acrocyanosis, they become dizzy, they can faint. Obviously, with energy lack, they can become lethargic as their energy lack increases, they often become constipated as the gastrointestinal system ceases to work normally. They obviously become amenorrheic as it's not nutritional deficiency or starvation is not consistent or helpful if you're planning pregnancies. So our body is designed to shut down growth and puberty and menstruation when we have prolonged severe energy lack. And the other impacts are on cognition and brain function, often manifest by poor concentration and also by changes in mentation that include mood and anxiety. So often we see young people becoming sadder and more anxious. I'm really interested in dietary intake, so what they actually are eating and how much they're eating, limitations and exclusion. Most young people that are developing anorexia will have food rules, and Deanna will talk more about that later, that changes in their dietary habits. So things like cutting out carbohydrates, deciding to be vegetarian, developing various allergies or food intolerances that may not have been medically checked or medically proven and are often associated with underlying eating disorder cognitions. So I'm interested in those changes and what they're actually having at the time, and then the behaviours that they're undertaking. So how much exercise they're doing, and sometimes that needs to be quantified. So if they're going for a run, how long are they going for a run for? How often? Is that does that seem a normal amount, and is it normal for where they are physically? Incidental activity, so many young people will be standing recurrently, so parents will tell me they won't sit down, they don't like sitting down, they're walking from one side of the room to the other and doing lots of incidental activity at home that doesn't seem to make sense to anybody. I'm also interested in work. Many young people that I see are working for quite long hours, and standing on your feet for 4 to 6 hours a shift or longer uses a lot of energy as well, particularly if you're not eating during that time, and many young people don't get good meal breaks at work. And then I'm also obviously interested in purging, whether that's vomiting or whether it's laxative use or other medication use. There is a screening questionnaire that we recommend for use in eating disorders. It's been shown to have pretty good sensitivity and specificity. It's quite old now, but still useful. So that screening, I'm not sure that it's a great name for it, but it's called the SCOFF questionnaire, and that's an acronym, obviously. Do you make yourself sick when you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost more than the original questionnaire said 1 stone, so that's about 6 kilos within the last 3 months. So you might ask, have you lost weight recently? Do you believe you're fat when others say that you're too thin? Would you say that food dominates your life? So for many of those people, food has become a ruling feature of their life, and it is dominating their life, and many young people will tell me it's their 24/7, their worries about food and shape. So 1 point for each question answered yes, and 2 or more points suggest maybe you need to delve a bit further and think about eating disorder for that young person. Okay, so when you're seeing young people, the main questions that I want to raise with you are really thinking, is this person medically compromised? So, and if so, you need to send them to hospital, and is this person at risk of suicide? And if so, you need to send them to hospital. So when you're assessing the severity, these are the questions that are in the forefront of my mind. How unwell medically is this person, and how unwell psychiatrically is this person, and do they need acute care right now? Some of the things we look at to suggest medical compromise would be blood pressure. So we're looking to see if they're hypotensive. You can also assess for a postural drop, and we're interested in a postural drop of more than 20 millimeters of mercury. So getting them to stand, wait for 5 minutes, check their blood pressure and see what the drop is. Practically, I will admit I don't often check the postural drop, but I'm always asking them if they're dizzy when they stand up, and many of them will tell you they're dizzy or have been fainting. That's a sign that they have postural hypotension, and I don't need to document it. I don't feel the need to document it if they're giving me that history. I'm sure that they have postural hypotension in that situation, and then that's a concern. Hypothermia is also important. Many of them will actually be really cold. Sometimes I have patients whose parents are having to sleep with them to keep them warm. they cannot maintain their body temperature when they get into severe energy lack. They'll often become bradycardic, and increasingly, because young people are wearing Apple Watches, they can come in telling me that my pulse rate goes down to 38 at night. That obviously worries me quite a lot. So anything less than 50 for children and 40 for adults is starting to get our concerns up. One of the newer features that people are looking much more closely at are significant postural tachycardia. So sometimes patients will be tachycardic because they're dehydrated, but we also check for postural tachycardia. So if you're doing postural drop and you get them to stand, you can look for postural tachycardia, which is just a marker of their difficulty with peripheral circulation and their heart's inability to compensate for their energy lack when they change position. So it's tricky. Bradycardia and tachycardia, I think, are a little tricky because often when young people come to see you, they'll be really, really anxious and their heart rate often looks falsely elevated. And I found surprisingly frequently that if I send them for an ECG to document what's happening, and I'm wanting to do that often to look for other conduction abnormalities that I've got listed at the bottom of my list, then by the time they've laid down, talked to somebody lovely in the cardiology department, have the ECG done, then it actually demonstrates more clearly what their heart rate is. So looking for bradycardia, that's quite helpful. I'm always concerned if their BMI is less than the 5th percentile. Essentially, that's not compatible with normal growth and development. So that's a marker for me that they're really at risk of needing hospital admission. Rapid weight loss is also concerning, so anything greater than 1 kilo a week for more than 4 to 6 weeks is likely to lead to medical compromise, and if that's what's happening, then we'd like to know about that person earlier rather than later. Obviously, severe dehydration or fluid restriction are important, so some people will go days without having fluids, and they're obviously at significant risk acutely of dehydration and may need to come to hospital immediately for that, even if they don't have other markers. Electrolyte imbalance, especially problems with potassium and chloride. Usually that's a marker of purging. So people who are reported to be purging, I'm more worried about that. Many people hide their purging, so it's important to check electrolytes if you're at all concerned about rapid weight loss and the potential for purging. Many young people, when they get into severe energy lack, will have low blood sugar levels. So levels below 3 start to get us concerned and might be a reason for admission to hospital alone. And as I said before, cardiac conduction abnormalities that might be associated with low potassium, but also as you become undernourished and have energy lack, you will get prolonged QT syndrome. And it's important to recognise that not only as a risk factor for cardiac arrhythmia, but also because it can be exacerbated by medications that we may use. So it's important to identify. The indicators of psychiatric risk are mostly about suicidal ideation and severe self-harm. And so I'm not going to go into how you assess that. You probably do that more frequently than I do, but it's really important to assess for how someone is managing from a mood point of view and how they're managing from an anxiety point of view, and check in with them about any suicidal ideation or plans to harm themselves. The other common reasons for admission to hospital are failed outpatient treatment. So if someone is not managing to progress on outpatient treatment, we may bring them in to review, re-educate and have multidisciplinary discussions about how to progress things. If the family is unable to manage the young person for a range of reasons, and obviously concerns about safety. It's important to document that or note that there is legislation about how to facilitate treatment. So many young people, as I've outlined in the diagnosis, particularly for anorexia, fail to see the severity of their problem. And sometimes families fail to see the severity or deny the severity of the problem as well. There are legal frameworks to assist us in ensuring that young people come to urgent medical care if it's needed. And those forms of legislation, I'm not going to go into great detail, but you can treat someone under a duty of care. That the difficulty there is how long you can do that for. Obviously, if families are resistant to bringing their child to care or agreeing to appropriate medical care, then the Child Care and Protection Act is important. And our DCJ colleagues are very helpful when we're concerned about people who are undernourished in particular. The Mental Health Care Act is for people who have who lack capacity to make appropriate decisions for themselves, and many young people with severe starvation syndrome will meet that criteria, and we use that not infrequently if there are significant problems. And in the adult world, the most commonly used legislation is probably the Guardianship Act, which is really for use when people are unable to make appropriate decisions for themselves because of their medical or mental health problems. So the management options available generally are reassure, wait and see what happens and keep watching. So if you're meeting someone and you're concerned, measure, document and keep seeing them more frequently. You can refer to a general paediatrician. General paediatricians should all be equipped to assess and help you with young people with eating disorders. Many have not felt comfortable, but there is increasing rollout of education, and within H&E Health in particular, or there's been a statewide guideline to say that all people should be able to access care close to home. So general paediatricians should be a resource for you in assessing young people, and it's worth picking up the phone and talking to someone if you're worried. You can refer to a dietitian plus or minus a psychologist, so they actually provide the mainstay of outpatient therapy, and we'll talk more about that. You'll hear more from both Deanne and Gemma later. Referring to CAMS, so the main public form or source of care for both dietetics and psychologists in our area is via CAMS, and you refer via the mental health referral line. When I first started working this field around 20 years ago, eating disorders were not prioritised in that system, but they certainly are now. And the rollout of support and training has been much increased over that period of time, so that this is core business for all CAMS services. And most patients, if they're adequately assessed and presented to CAMS, should be accepted. You can also refer to eating disorder medical assessment clinics. So we have one at the John Hunter Children's Hospital. Usually if you're referring to that clinic, I would suggest that you refer to CAMS at the same time, and they would come for medical assessment. There are some families who deny the mental health aspect of the illness, but they're happy to come for a medical appointment. So they can access care via either arm. And if you're worried, you need to send them to the hospital emergency department, the closest department, depending on where you are. All emergency departments within H&E Health have been allocated training to identify eating disorders. And again, this is something that was notoriously difficult in the past, but is improving, but still there's a way to go. If you're concerned about someone and you're worried that they will either not present or get turned away from an emergency department, please call and discuss. There will be an adolescent physician or fellow at the John Hunter during routine hours. There is always an on-call registrar or paediatrician at your local paediatric service as well that should be happy to discuss the management of eating disorder patients. The typical medical management for these patients involves medical refeeding and avoiding refeeding syndrome. So patients who have been malnourished or starving for a period of time are at risk of difficulties with fluid and electrolyte fluxes, which we identify as refeeding syndrome. The primary or the most commonly noticed problem is a drop in phosphate, but there are other fluid and electrolyte changes that can be really dangerous, including cerebral edema and difficulties with electrolyte change and arrhythmia. So it's important to recognise that. We're particularly keen to monitor for that in really malnourished people who we're bringing to hospital and refeeding more rapidly. We refeed rapidly if people are yet medically compromised, because the risk of continuing to allow them to be compromised is counteracted by refeeding, and that is the mainstay of medical treatment for this patient group. So that might be orally or nasogastrically. If you come to hospital, it's likely that you will have nasogastric refeeding, because the main criteria for admission to hospital is medical compromise, and the fastest way to stabilise the body and help that medical compromise is by feeding sufficiently. And if you're unwell enough to come to hospital, the likelihood that you can turn that round in 24 hours is extremely low. And so nasogastric feeding is likely, and is also the slowest and safest way to refeed someone. The other factors that we address in medical management are things like medical investigation. So it's really important to make sure that we aren't missing other medical diagnoses like hyperthyroidism, diabetes insipidus, gastrointestinal diseases that might lead to malnutrition, and other illnesses. Most of the time, the medical history gives a fairly good outline, but we would routinely provide some investigations to exclude other pathologies. We also make sure that during medical assessment, in hospital, we arrange a psychiatric review, and that's to assess and discuss diagnostic criteria and look at diagnosis and management of comorbidities. Many of the patients have other psychiatric comorbidities, particularly depression and anxiety, and some of that is related to the starvation itself, but some of the comorbidities may be pre-existing. One of the other major features of initial treatment, and particularly treatment in hospital, is containment of anxiety and distress, and we're very grateful for the help that our psychiatry and psychology colleagues give us with this, but it's a multidisciplinary process and our nursing staff are trained to help. We also are very lucky in our department to have a hospital school who play a big role in helping to manage anxiety and distress for our patients as well. So all of the team are involved in helping with these factors. As the young person improves and their eating improves, we help them to return to more regular inclusive eating. So we challenge food rules, and Deanne will talk more about that again later. And we like to make sure that we're not perpetuating abnormal beliefs about limitations in their diet. And then we also help them with normalisation of activities, again, as nutrition improves. So typically, if young people come in medically compromised, they will be on bed rest initially, as all their energy needs to go to helping their body stabilise. As they improve, they will be allowed to walk around the ward, they'll be allowed to have some leave, they're encouraged to attend the schoolroom and have a more routine day, as the having a routine to your day helps with anxiety, but it also helps us look at normalising the energy requirements for that young person. The other role that we have is helping discuss the appropriate management moving forward, and for most of these patients, it's advocating for family-based treatment as the first line of care in young people. I've put in, I haven't talked a lot about meal support, but one of the main features in hospital is supporting them to return to normal regular eating. And we have mixed meal plans and supervised eating, supervised by nursing and dietetic and psychology staff. And this is what our meal support room looks like. We're packaging and all the information, we try to remove all the information that talks about quantities and calories from their food and encourage them to eat in a more normal, structured way in a family style at a dining room table, supervised by the nursing staff who will document what they've eaten, and what isn't eaten will be supplemented, or they will be offered a supplement to make up the calories, because we're saying to these young people that they need to have enough food every day till they get well, and they will usually remain in hospital until they can eat sufficiently to do that without supplements or nasogastric feeds. So I said the main form of treatment is Maudsley family-based treatment. It's an evidence-based treatment preferred for children and adolescents, particularly those with anorexia, atypical anorexia, and it's also being used in ARFID, though in ARFID it's modified often with a CBT component as well. It's an outpatient-based treatment, and it continues for around up to 12 months. The parents are the prime resource for refeeding their child, so they're vitally important as part of the treatment team, and they're the main supporters of eating. The parents themselves are supported by a therapist very regularly, so to begin with, these are weekly treatments or weekly sessions, and they're supported by a paediatrician and psychiatrist as needed. It has good outcomes for children 10 to 18 years within 3 years of illness. So we talk about within 3 years of illness onset as being early onset. And the outcomes are around 75% recovery at 5 years with that particular model. So outpatient care, and I'll reinforce, and I think Gemma will talk as well, to say that Family-based treatment doesn't start in hospital. So hospital is about medical stabilisation, about psychoeducation, about helping define the three main goals that I put to families are that we medically stabilise your child, we help them to get back into a normal eating pattern, and they need to be able to eat sufficiently that they don't need supplements or nasogastric feeds. And then we help you define the next step, which is outpatient care, who your care team will be and what that care will look like. And that is set up in hospital, but treatment doesn't begin till you're an outpatient. A formal treatment doesn't begin until you're an outpatient. And then outpatient care is usually supported by a multidisciplinary team. So that might be CAMHS clinicians, who typically include mental health trained nurses, psychologists, social workers, or with private psychologists and dietitians. And as I said before, it's usually a weekly session that they have at least. They may see the paediatrician every 1 to 3 months, depending on the acuity of the illness. The general practitioners, we would often ask to see the patient every 1 to 2 weeks initially, and that again is getting familiar with what's happening for the young person and helping to monitor their medical stability. And then maybe other general support services like Headspace or school counsellors that help provide assistance as well in those spaces. So what is expected of GPs? We're usually asking GPs to have regular review regarding medical stability and requesting that you share information with the treating team. It usually doesn't include weighing. That will usually be done by the family-based treatment team. It is negotiated, so this will be different for different patients, but it's something that I think can be a bone of contention, and it's important to recognise that that needs to be negotiated for each family. But as part of typical Maudsley family-based treatment, the young person would be weighed during that treatment. And it's confusing to do weights in multiple different places at different times. So we would usually ask that you don't necessarily need to do that, and the treating team should liaise with you about that. But we do expect monitoring of pulse rate, blood pressure, temperature, blood tests, ECG as needed, and checking in regarding psychiatric stability too. So that will flux and change, and there are lots of ups and downs along the course. Liaising with the extended treatment team is really important, so that might include CAMHS clinicians, dietitians, psychiatrists, paediatrician as needed. Helping avoid team splitting by supporting a unified approach and liaising if there are concerns. So Gemma will talk a bit more about that later. And then including parents as the main therapeutic support for the young person. So the parents are the main source of support for young people with eating disorders. So it's really important that they are part of that team and that you include them in care. So I just added this because I love graphs to show you what recovery might look like. This is a young person who really in the first illness, so this is a young girl with anorexia who presented quite young. So we see children even down to as young as 8 who have full anorexia, but many of our young children have more of an ARFID diagnosis. This girl presented with anorexia at around 11, and she struggled in the first year of her illness with us to recover, but subsequently with some other changes and supports has made a great recovery, and her BMI has now risen to around the middle of the healthy range. And along with that, you can see on her height growth that although her height had stagnated and she'd fallen across centiles for her height growth while she was undernourished, excuse me, as she's improved, her height has caught up, and she's nicely progressed from the 3rd almost to the 25th centile for her height, which is a great sign of improvement. So I just wanted to flag a few support services. The Inside Out Institute is now the major professional support service for New South Wales. It's actually a national body doing research, but it's based in Sydney. And they have lots of great resources on their website, including a database of services that are available in different areas. The National Eating Disorders Collaboration also has lots of resources relevant to all areas. The Centre for Eating and Diet, actually it's not the Centre for Eating and Home Disorders, it's the Centre for Excellence in Eating Disorders, is the Victorian, the CEDD, which I've reference there, and I'll change these slides, was actually the old New South Wales service, but the CEED, C-E-E-D, is the Victorian service and has lots of good resources on their website, so still a useful place to look for resources. And online resources for families themselves. The main support service or support organisation in Australia is the Butterfly Foundation, which does have helplines and really useful resources for families. But there are a number of other online websites, mostly American-based, including Maudsley Parents, Feast and Around the Dinner Table, provide practical support for parents and are also good sources to let families know about. The area-wide supports, so there's a Community Health Pathways online. I'd really like to encourage you to access that for those within H&E Health. There are community health pathways for eating disorders. I would expect them to fall under the medical categories, but they're actually listed under mental health. It is a mental health diagnosis after all, and there is separate pathways for adults and children. They're quite comprehensive and have really good links. The CAM services and the mental health helpline are also good places to call if you're after referrals or information about eating disorders. They should be resourced to understand and screen far better nowadays than they were in the past. The paediatrician on call at your local paediatric centre via switchboard should be accessible and able to talk to you about concerns regarding medical compromise in young people with eating disorders, and concerns where people are losing weight and you're worried about other medical conditions, obviously. Child and adolescent psychiatrist on call. Most places are going to have one of those. Catching them might be hard, and some of the positions are not filled all of the time, but they're useful people to talk to and will be able to point you in the right direction. And then within H&E Health, Mel Hart is our eating disorder service lead and has been for many years. She's probably one of the most well-educated and knowledgeable people about eating disorders in our area. She is also contactable, and she's part of a new multidisciplinary team that Gem is also part of, that's actually to help with training and consultation for H&E employees, and so for the teams working within our area, not specifically designed for general practitioners, but if you're having difficulty with referral and not being able to access someone, then or access the care that you think you need for a young person, then she's happy to be contacted, as am I, either via our secretary or the switchboard that I've listed there. And that's the end of my section of the presentation. So I'll pass over now to Deanna. Deanne.
Deanne, you're on mute.
Oops, sorry, I thought I unmuted and it didn't. I've got a new computer and it's not working very well. Sorry, it's still configuring. Can you see my screen?
We can, but do you have the presentation in on another screen?
Well, that's what I was just trying.
Yeah, if you drag it across to where you've got GoToWebinar open, where you can see, yep, because when you click on it, it looks like it. Yep, it's down there. If you just drag it up, you can see it down the bottom there.
Yep, but it won't let me. That's what I'm saying. Sorry, my new computer's not letting me do the things I want it to do for some reason. Hang on, maybe now. Sorry, everyone. It just
no. Excellent. So that's in presenter mode.
Yep.
So if you just, because you've got it on two screens, just want presenter. Yep, that's the one. Yep, all good to go.
There we go. Sorry about that, everyone. As I said, I've got a new computer today and I actually don't quite know what I'm doing with it. So thanks, Julie. So I'm just going to talk a little bit about dietetics and some of the specific nutrition things that it's very helpful for GPs to think about when they're talking to young people and their families, but also just to give you a bit of an idea of where dietetics fits in the treatment team, because the role of dietetics, particularly in eating disorders, has fluctuated over the years. And I guess our focus in terms of treatment for eating disorders has changed as well. So at the moment, we tend to have a fairly significant role, especially early in diagnosis, while medical risk is high because refeeding is one of the biggest priorities in terms of treatment naturally. Whether the young person is in hospital or as an outpatient, we will tend to be heavily involved early in that diagnosis, whether we're working with the parents or the young person or both, while we're trying to refeed. In hospital, we would actually see the young person generally nearly every day. We negotiate tube feeding if it's required. We often coordinate meal support therapy with the nursing staff. We have fairly prescriptive meal plans in the inpatient unit, but we also may be doing that in the outpatient unit. We'll tailor an individual's nutrition care to actually correct nutritional deficiencies, so particular things around their calorie deficits, but also if there's specific nutrients that they're missing. So for example, if they're iron deficient or zinc deficient, or they have a really poor intake of calcium, those sorts of things. So we'll be specifically looking at individual nutrients as well. We try and help young people and their families understand the interaction between food, nutrition, and their actual well-being, particularly because often families present not for the eating disorder, they'll present for something like irritable bowel or constipation, as Julie was mentioning before. So sometimes we need to actually provide some education around the whole body and how food fits into the functioning of the whole body, because often people really struggle with the diagnosis of an eating disorder and find a diagnosis of irritable bowel, for example, much more acceptable. We'll look at things around optimum nutrition status for that individual. So if it's a young person who is extremely tall, for example, they'll need a much higher level of calorie intake than a young person who's much smaller at the same age. So we'll spend a lot of time talking to young people, often around body shape and type, and because often, particularly as you know, peers compare each other amazingly. And one of the things we find is that a lot of young people will say, but my friends don't eat that much, or you know, my friend from school only eats once a day, or my friend doesn't eat at school. And so often what we have to try and talk about is what's actually appropriate for them, not for everybody in general. We do a lot of stuff, as Julie said, around nutrition education about inaccurate beliefs and food rules, and I'm going to give you a few examples of those in a minute. And we actually do tailored guidance for families around specific nutrition goals for that individual to actually maintain growth as much as we possibly can, or improve growth if growth is actually faltered, for the physical health, psychological and intellectual development as well. Because often what we'll find with some of the young people when they present, particularly to the GP, is if they have had the eating disorder for a little while, often their mentation is quite slow, and you'll actually find that their thinking is compromised, and we need to work around that as well in terms of their calories to actually get them functioning a bit better, so they can actually take in what's being said around them. So as I said, we support eating behaviours that assist the treatment and recovery goals, so whatever that may be for that particular young person. We try and, as I said, improve the cognitive functioning as much as we can through adequate nutrition, because it's very hard to work on psychological therapies if your brain's not working particularly well. So we really try and work on thinking if we can. One of the things we spend a lot of time working on is nutrition intervention to manage or decrease the physical effects of the eating disorder itself. So things like constipation, dehydration, altered electrolytes, particularly things like sodium caused by water loading, for example, where a low sodium may happen when a young person is drinking litres and litres of water. Or it may be potassium because of compensatory behaviours, so things like purging, laxatives, those sorts of things. And we'll be working to actually try and target sometimes even specific foods. So it's not unusual for me to sometimes ask a young person to have a banana every day, for example, to try and improve their potassium levels if they're purging. We look at the nutritional management of therapeutic diets while we're treating the eating disorder, because as Julie mentioned, lots of young people, unfortunately, with more restrictive type therapeutic diets develop sort of disordered approaches to eating. So type 1 diabetes is unfortunately very common. Food allergies, particularly things like celiac disease, ADHD, ASD, those sorts of things can actually have an impact on the variety of foods that young people are eating. We try and look at a weight neutral approach, so looking much more around the functionality of the body and teaching people how to appreciate the body for the marvel that it actually is. We do quite a bit of body image work at times, but often later in treatment, so not so much in the early stages. We do quite a lot in stage 3 of family-based therapy, which Gemma will talk about the stages in a minute. but a lot around the enjoyment of food and the role of food in our society, because food is nutrition, of course, but it also has a role to play in our psychological well-being as well. What we don't do, but we're not the food police. It's very, very rare and should never really happen that a dietitian is the sole treatment provider for an eating disorder. We really need to work within the MDT for effective treatment. Ideally, it's what we call the triad of care, so a medical practitioner, psychological practitioner, and a dietitian. But at least the minimum should be, particularly in the early stages, a medical practitioner and a dietitian, and then bringing in mental health as the young person's well enough to actually engage in treatment. We can't manage that medical or psychological risk, as I said, so we need to escalate if there are medical or psychological concerns from a safety perspective. So we do risk management. We do ask questions around suicidality and self-harm when we're in a session with a young person, but we cannot actually manage that ourselves. We need to escalate that immediately. We also can't focus on weight loss, and particularly still with atypical anorexia growing, some of those young people, or particularly even with bulimia or binge eating disorder, our young people might present in a larger body. And so from a society perspective, the first thing everybody thinks is if that young person loses weight, they'll feel better, and that might actually decrease their risk of the eating disorder because they're feeling better in themselves. It's actually physically impossible to focus on weight loss and effectively treat an eating disorder. And just for interest, the risk of an eating disorder in a young person who actually is on a diet is 18 times higher than a general population of adolescents. In terms of the groups that we really focus on from a dietetic perspective, there's a few that are probably more at risk. So females, especially during biological and social transitions, so things like the onset of puberty, changes in relationship status. Unfortunately, we get lots and lots of young people following a breakup in a relationship, and it may not be actually a romantic relationship, it could be a friendship, could be a move, anything that's sort of, even a breakup within their parents, anything that changes the relationship status within their family. Things like pregnancy, changes in social roles. As Julie mentioned before, adolescent risk is the highest between 13 and 17 years of age. And with anorexia, on average, most of our patients, unfortunately, are getting a bit younger. So it used to be around 16, 17 that I used to get most of my clients, and now it's around 13, 14, 15. The other thing that is a high risk in adolescence is competitive occupations or sports, things like performing arts, and anything that emphasises body shape or weight requirements. So modelling, gymnastics, athletics, and anything with a weight category. So it may be things like martial arts, boxing, those sorts of things. So unfortunately, that muscular but thin build is becoming sort of the desirable shape at the moment. And so that puts pressure on young people to be a certain physique, which is actually very, very impossible to attain when you're an adolescent. So it sets up a bit of a predisposition, unfortunately, to try and achieve an ideal body type. So young people in the LGBTQIA+ communities are way more at risk of disordered eating, particularly if they're trying to change their body to present more the gender that they're identifying with. One of the most common things I've seen recently is in young women starving themselves to cease menstruation because they want a more masculine body, and periods naturally don't fit with that. Neurodiverse young people with restrictive eating patterns, so people with ASD, or even sometimes with ADHD, that can contribute. Type 1 diabetes, as I said, food allergies, things like celiac disease, restrictive therapeutic diets. So one of the I guess, diets that's a bit of a risk at the moment is the FODMAP diet. So young people who present with anxiety and may have some irritable bowel type symptoms, given a FODMAP diet, it can be quite restrictive. If they don't then loosen it up like you're supposed to, it can actually lead into anorexia, unfortunately. Vegetarianism and veganism, and one of the things we often do is discuss with families if the young person is vegetarian, when they became vegetarian, because if it predated the illness by a long way and that's the family's preference, that's absolutely fine. But if it's actually sort of presented and tied in with the eating disorder, then we really need to challenge those food behaviours. Who we tend to work with depends on the treatment modality. So if it's a family that's doing FBT, we tend to work more with the parents than the young person, particularly in the early stages of treatment, to enable the parent to refeed their young person. But we often then step in a little bit more in what we call stage 3, where the young person gets some more autonomy to actually work with them around that socialisation of food that I was talking about before. With some families, we use what's called the RAVES model, and I'll talk a little bit about the stages in a second, but that can be with the young person and their family, whether we're doing FBT or not. It can be a really useful way to actually educate the family in the steps that need to be taken to refeed their child. As I said, we tend to work closely with the MDT. One of the things as dietitians, we also work particularly with the things like sporting clubs, coaches, schools, particularly if in some of our rural communities, we have a number of young people that come to boarding school, and we'll often work fairly closely with the schools as well in terms of the care of that young person. In terms of that RAVES model I was talking about before, it's a 5-stage model, and it basically gives you a bit of a way if you're talking to your young person or family, and for you as GPs, this could be quite useful just to have a think about in terms of the steps a family needs to actually help their child recover. So the first step is regularity. So the first thing is actually around getting people eating much more regularly, because one of the things, of course, that generally presents with any eating disorder, whether it's bulimia, binge eating disorder, or anorexia, is a fairly strong period of restriction and very irregular eating. We then move into adequacy to actually try and meet nutrient requirements, whatever they may be for that particular person. Once that's done and the person is a lot more medically stable, so between regularity and adequacy, you actually improve medical stability. We then work on variety, so actually looking at the relationship with food, eating socially, and then eating a bit more spontaneously and not being quite so rigid. So in terms of our goals, we're looking at weight restoration if they're underweight, adequate nutrition for growth and pubertal development. So one of the things that we work hard with the families and young person is to get, particularly for females, if their body fat percentage has fallen too low to actually menstruate, one of the things we're looking at is actually at body composition to try and get their body fat percentage back up and get their menstruation resumed, particularly because of the risk for bone health. So we're really trying to focus on that. Weight goals are often a bit higher than their pre-illness weight, particularly if the illness has been over an extended period of time. So if the young person's been unwell for a while, often they'll have it very fixed in their head. I've only ever been 50 kilos, but they might be 2 years older now, so the goalposts have to shift naturally, which is why when Julie was showing you the plotting on growth charts, it's really helpful. And I often show young people how the growth charts change. I may not show them a growth chart with their numbers plotted all over it, but I actually show them the trends of the growth chart so that they can see that from 15 to 20, often females particularly, their height doesn't change much, but their weight changes because their body's still developing. And sometimes that actually helps them get their head around the fact that weight does actually have to go up as we get older. As I said, nutrition fermentation and actually trying to get the brain working properly. We work a lot on the compensatory behaviours, so things around purging behaviours, laxatives, exercise to normal amounts, food rules, and then, as I said, the variety and social aspects of food. So things in terms of the tools that we use, we might use things like meal plans very early on in treatment, looking at trying to get regular meals and snack times, making it fairly planned, making sure that there are some food-free times in their world, because one of the things that for families becomes, particularly in anorexia, is food becomes the center of the universe for the whole family, which causes a lot of distress. Meal times can take a very long time, and so sometimes families feel like they're doing nothing but planning, preparing, and then eating meals, and then sitting and working with their young person to try and get them to eat their meal. So we try and actually make sure that there are some food-free times in their family as well still, and we'll often work with the psychologists on that. In terms of the physiological changes, I guess just in terms of growth, just to remind you, and you all know this better than I do, but adolescents gain 20% of their height and 50% of their weight during this period, and a lot of our families don't know this, so I find it incredibly helpful to educate families on the amount of growth that an adolescent has to do. So as you know, Boys grow between 28 and 51 centimetres and gain up to 54 kilos. Females grow between 21 to 25 centimetres and gain up to 50 kilos as well. Our skeleton doesn't stop growing till we're around 19 years for girls and 22 years for boys. I often show this picture in consults too, just to show them all of these boys are exactly the same age, but as you can see, the sizes are quite dramatically different. And so, unfortunately, adolescence is a time we spend comparing ourselves to everybody, and it's not really the time that you can compare bodies, unfortunately, because everybody is different. In terms of the nutrients that we focus on, these are often the primary ones that are a problem. So energy, naturally, we mentioned before. Calcium for a few reasons. One, because often dairy is avoided because of the fat content. It's also incredibly trendy at the moment to use things like non-dairy milks, like oat milk and those sorts of things. And unless they're calcium fortified, the calcium in those is incredibly low. Iron is a major problem because often for a few reasons, red meat can often be avoided, but also some of the carbohydrate type foods that contain iron, like breakfast cereals, for example. Zinc, because most animal products are often cut down. Vitamin D, for a couple of reasons. One, because often our young people tend to be not feeling particularly great, so they may not be going outside a lot and getting vitamin D, but they also don't eat a lot of fat, so they're not getting their fat-soluble vitamins. Macronutrients, particularly carbs. What we find at the moment, protein's quite trendy, and even healthy fats are a bit trendier than they used to be in terms of young people being okay to eat them. So often I find young people will eat avocado, for example, but they won't eat a carbohydrate to save their life. And then fluid is often the other thing. So what we find is that with young people with eating disorders, they fluctuate. So some young people will drink ridiculous amounts of fluid, particularly water. I've had one young person drink up to 9 litres a day and had a sodium that was 21, I think it was. And other young people will barely drink at all because they can't stand the feeling of the fluid slushing around in their stomach. So they also are very, very conscious of any distension of their abdomen. So when you have a big drink, naturally your stomach pokes out for a short period of time and they can't cope with that at all. Sometimes we do need to use supplements, and we often need your help as a GP. For that, we do need to correct nutritional deficiencies a bit quicker than what we can do at just food alone. And so we will actually look at that if we need to. I do quite a bit of education around the Australian Guide to Healthy Eating, just to give people an idea of the actual amount of food that people generally need just for growth, because we have to remind parents particularly that young people aren't midi adults. They don't need the same food as an adult. They actually need, often in an eating disorder, up to 3,000 or 4,000 calories a day for recovery, which is a significant amount of food and much more than most adults will need. So we really need to emphasise to parents how much food recovery actually takes. So just to give you a pictorial example of that, this is just a basic one. So just looking at a rough day, and this is someone who's actually been weight restored and we're trying to maintain, because often our young people are, particularly if they've had anorexia and had to be refed, they're often quite catabolic for a little while and they burn significant amount of calories. So just for weight maintenance requires a significant amount of food. In terms of the food rules, I just thought I'd give you a few that I often get told. So just things like I can't eat after 6 o'clock, so they'll try and pack all of their food in. And then of course they often present with very low blood glucose first thing in the morning because they have no glycogen stores and their blood sugar drops through the night. So they can often be, as Julie mentioned, bradycardic and things, but they can also be hypoglycemic as well. I've had young people that won't eat anything white, so no white rice, no pasta, no bread, those sorts of things. No liquid calories, so they'll drink water, but they won't drink anything else. They might only eat once a day. They'll only eat fruit in the daytime until dinner because they have to eat dinner with their family. If they eat more than fruit, they might need to induce vomiting and purge. I've got young people that'll drink something like 1 litre of water at each meal before they'll eat anything to try and fill up so that they only eat small amounts. If their weight is less than it was yesterday, they're allowed to eat. If it's more than it was yesterday, they're not allowed to eat that day. I've had young people aim for certain measurements of their waist, for example, and they'll measure obsessively. And if their waist changes, they'll stop eating and they won't eat the next day. So those sorts of food rules are often things that we challenge, and often I'll get young people to write a list of those food rules. And it can be quite helpful to then gradually over the time we keep coming back to the rules and challenging them as their health improves and their thinking clarifies a bit. We can start to really challenge some of those things with some behavioural experiments, and that's really helpful with the psychologist in FBT as well. The other thing, as Julie mentioned, was weighing, and I just thought this is just about my last slide, but I just wanted to mention around weighing a couple of the things that we need to think about. So the MDT needs to decide who weighs, as Julie mentioned before. It's very complicated and very threatening for a young person if every single person is weighing them. We also need to make sure that the psychologist or dietitian is very clear about if they're doing FBT, they're weighing, they're having those discussions. There has to be good communication across the team so that the information is timely. So if the GP is not weighing the person and the psychologist or dietitian is, we need to make sure we've got a really good communication for you so that you actually know what the weight is when the young person comes in. As consistent as possible. A lot of our young people are incredibly rigid, so they get very distressed if anything changes. Same scales, light clothing or underwear, depending on where the situation they're being weighed. No shoes, empty pockets. We also need to educate parents quite often, and I often spend quite a bit of time around this, around things that you can do to manipulate your weight, because parents are so caught up in the number that they get very distressed if they think they've been trying really hard and the family's working really hard for the young person in recovery, and then they don't gain weight. So things like water loading, hiding items in their clothing. I've had young people hide weights, 2 phones, as many keys as they can find, all sorts of things to actually, I've had young people stuff things in their underwear just to change the weight so that they think they're getting a better outcome, and then they can go home and hopefully go back to doing what they wanted to be doing. The other thing that we need to think about in terms of risk is where the young person's at in their illness and whether knowing the weight is helpful or not. So at some stage in treatment, we always need to discuss weight. We always need to actually work on that, because accepting your weight and shape and size is a really important part of treatment. But there are stages in treatment sometimes where there's a higher risk, and we need to work out whether a blind weigh or an open weigh for that young person is the most appropriate, depending on where they're at. And the whole team needs to agree for that as well. Because if one member of the team is blind weighing and everybody else is open weighing, it just adds more confusion. So it's actually really important that we get the weight sort of agreement between the team really set in place before we start treatment. And I'm just going to hand over to Gemma now.
Thanks, Deanne. I hope everyone can see this. I'm sure someone will tell me if they can't. Thank you, Deanne and Julie. Very
Not
helpful.
yet. We can't see it yet. Do you want?
Can't see it.
It says waiting to view screen. Give me a second. I'll try again. Here we go.
Can we see it now?
But no, it says waiting to view screen. In the tab in Go To, there's a little button that says sharing and a big, yep, we've got it. Thank you.
Got it? Awesome. Okay. So I'm going to just talk, I'll try and keep it quite brief, about the role of psychology, especially in the assessment and treatment of eating disorders and what that might look like. I want to give you guys a bit of information about what the therapies look like as well, because I know for me, if I'm referring someone for a specific therapy, it's nice to have a bit of information about what that's going to look like in case they have any questions. I suppose first and foremost, the role of psychology is having a comprehensive assessment that has a really strong consideration of the psychological factors that are going on. So Julie and Deanne have previously touched on a lot of the nutritional and eating disorder behaviours that we're going to assess, and that is the core part of the assessment. But for myself as the psychologist, I'm looking at some other perpetuating factors such as anxiety or obsessive compulsive traits, any avoidant or safety behaviours. Especially for children and adolescents, you really want to look at their sense of self and where they are in that development and how they identify either with the eating disorder or other aspects of their sense of self. With children and adolescents, you really want to include the whole of the family in the initial assessment and then ongoing throughout therapy. And what's really important there is that you're going to get a lot of collateral information, especially the eating disorder can often tell young people to hide the behaviours or to minimise them. So it's really important to get that extra information. But it also gives you a bit of information about other reinforcing factors that might happen. So sometimes young people with an eating disorder can have that reinforced because it almost gives them a certain role in the family or a bit of extra attention from their parents or from their siblings, especially if they do come from a family where there are a lot of siblings or a lot going on in the house. Another thing just keeping in mind in the assessment is any external drivers or psychosocial events going on outside of the young person. So if there's a trauma history, if there's domestic violence going on, if there is just limited access to food or those family dynamics or family mental health history that's playing a role. And the other thing that Julie touched on as well is the really high risk of suicide and self-harm in these populations. So part of that assessment for me and ongoing throughout treatment is really looking at the suicidality or self-harm and when that may emerge and safety planning around that with the family. But essentially from this information, I try to pull together a really strong biopsychosocial formulation and share that with the young person and their family. And then that formulation then goes into developing a treatment plan that's very individualized for that person's needs. So as far as inpatient treatment, as Julie touched on, there's certain goals, but there isn't really a strong role in psychological formal treatment as such. The mainstay is the meal support therapy, so that's essentially just your supervised eating. But as far as a psychologist role goes, we're really looking at doing some psychoeducation, either with the young person and family, or even with staff on the ward that are having to manage the distress or the eating disorder behaviours that pop up during those meals. And the formal psychological treatment will occur as they are discharged out. So the two main outpatient treatments for young people that are evidence-based are family-based treatment or the Maudsley model, or CBTE/CBTAR for ARFID, with a referral to CAMS, which is where I do a lot of my eating disorder treatment. They're the two main ones that we'd probably go with when a young person comes to us, but there are a few considerations that I'll talk about later that need to come in. I've also just got there as well that there is growing evidence to support some other treatment modalities. At the moment, that evidence is mostly in adults though, but I'm hoping we'll get a bit more growing in the child and adolescent space as well. So as far as FBT goes, it is the first line treatment for children and adolescents under 19 that are medically stable and have a shorter duration of the illness. It goes over 3 phases and you're looking at approximately 20 sessions, give or take. I usually go a bit longer because I like to be thorough. With phase 1 looking at weight restoration, and that's the primary, you can see there, sessions 1 to 10. So that is the majority of where the work's going to be done, is in that weight restoration. And I'll talk about the phases a bit more. Before I get into that, there are some fundamental assumptions with FBT. So first and foremost, neither the parents nor the young person are to blame for the illness. I think there is a lot of stigma around eating disorders that people say, you know, it's a diet that's just gone too far, you should have control over it. Or when we're talking about children and adolescents, what are the parents doing? They're not controlling this, what's their stance? No one's to blame for this. It is just an unfortunate circumstance that happens in some families, especially where there is genetic loadings. What we like to do in FBT and with most eating disorder treatments is externalizing the illness from the person. So essentially saying that the eating disorder is the problem, not the person who has the eating disorder. And when I work with a lot of families and young people, we do like to name the eating disorder. So lots of young people will call the eating disorder Anna or Ed, or sometimes bully, depending on, you know, what they're comfortable with. And then it can be very easy to say, well, I can see that Anna's very strong or got a very strong hold on you today, or what's Anna telling you to do right now, and it just helps create a bit of distance in that relationship and really alleviate some of that blame and stigma that goes on. There are some contraindications for FBT though, so of course if there aren't any parental figures involved in a young person's life, it's not going to work, because essentially what we're asking is for parents to take responsibility for that weight restoration. The other thing just to consider as well is whether the parents have their own mental health concerns or psychosocial issues. Essentially, if they don't have the capacity to take control of food and eating behaviours at home, FBT is not going to work for them, and we're going to have to look at alternative options. I will just say, though, that FBT has been shown in the research to be effective with separated parents, where people might live between two households. That might bring on some extra challenges, though, and some that I've had myself, where you've got to either have separate appointments because parents can't stay in the same room together, or it creates extra distress for the siblings. So it might be a little bit of extra time and resources, but it can be effective where indicated. So stage 1 FBT is looking at weekly sessions. Essentially, the goal in stage 1 is for parents to take control of the food away from the eating disorder. We really just are focusing on that weight restoration and getting back to a normal practice of eating. First and foremost, we start with the family meal. So the whole family brings a meal into the session with the psychologist or the clinician working with them, where parents agree what is enough food that will be challenging for the eating disorder. And as the therapist, you sit back and observe until the eating disorder has taken control, and then you begin coaching and assisting the parents to encourage the child to keep eating, and just by giving consistent messaging and problem solving and making sure parents are staying on the same page, because often what you'll see is the eating disorder will try and split, and I'll talk about that later, and maybe a father will come in and say that's enough food, and the mother will say no, she needs to eat more. So it's really important to get everyone on the same page in this early stages. And my mantra in FBT is food is medicine. Just like parents would give medicine to their child for any sort of physical illness, for an eating disorder, food is the medicine, and that's what we keep saying throughout treatment. This picture here just sort of goes through what it looks like. We absolutely include siblings in these appointments. They are a support to their sibling with the eating disorder, and sometimes they come with their own anxiety and distress, and being involved in treatment, at least in some aspects, can help alleviate that and let them know that there are people who are working towards supporting their sibling with the eating disorder. So just for the rest of stage 1, after that first family meal, it's really just aimed on keeping the family focused on the eating disorder and taking charge of the eating. With those sessions, we do bring the young person in first and do their weight if that's what's been negotiated, and we then bring the parents in afterwards, and essentially the theme of the session then goes from whether weight has increased or decreased or stayed the same will be what we talk about in that appointment, what's worked well, what hasn't worked well. In stage 1, one of the things I really want to highlight is young people are often really highly anxious or distressed after mealtime and before mealtime, but especially afterwards, because they are, as Deanne pointed out, eating quite a lot of food that goes against what the eating disorder is telling them. So in that first assessment, it's really important to look at what coping skills a young person and family have to help with that anxiety. And it might be built into this stage that we look at some of those strategies and building on that. So things like distraction techniques, self-soothing, imagery, mindful breathing, all those sort of lovely psychological skills. Stage 2 moves from weekly to fortnightly sessions, and we then hand control from the parents back over to the young person. So once they're able to demonstrate that they can eat well and gain weight, we start to give them more control over their food choices and their meals and preparing their food as well. Of course, this is indicated by their stage of development, and you know, for example, a 17-year-old might be more than capable of cooking dinner for themselves a few nights a week, but we wouldn't expect the same for an 11-year-old. We also start to encourage really normal adolescent activities in this phase. So previously and during hospital admissions, of course, and thereafter, it's going to be really hard to do sleepovers or school excursions. So this is where we really want to look at that and problem solve and see how we can make that happen for the young person as well. And then in the last stage, which is sort of the last 3 to 4 sessions that are really spaced out, hopefully monthly at this stage, we really just go back to just your typical sort of adolescent issues or issues that have been raised in the family. As Deanne had pointed out, the intensity of doing FBT and having someone with an eating disorder in the family can bring a lot of distress for everyone. So this sort of area is really looking at, you know, what's gone on, can we problem solve it, can we resolve some conflicts or things that might have happened or hurt feelings, and really just get a normal sort of sense of normalcy, around food, and maybe even enjoyment of food there as well. This one here, I just wanted to add in as well about just making sure that everyone's on the same page in our treatment process, and especially when we're terminating treatment at the end of FBT, it's really good to have a plan about who's there to support who and what we're looking for if an eating disorder does re-emerge. A lot of the times I will encourage people to go back to previous stages of FBT and see if they can put some rules in place, or it might be about seeking support from their GP, paediatrician, or coming back to treatment with myself as well. Alternatively to FBT, you do have CBTE, so it's the first line treatment for adults with various eating disorders, but there is strong evidence for children and adolescents, and also with children and adolescents presenting with ARFID. It again is primarily outpatient, and you're looking at about 20 to 40 sessions, looking at that interaction between your thoughts, your behaviours, your emotions, and how that is continuing the eating disorder behaviour. We really look at normalising eating, graded exposure to feared foods, so things like takeaway or high calorie foods, and then monitoring and challenging any distorted thoughts around food, weight, shape, sense of self, all those extra things that come on board. And this is just a very basic CBTE formulation for bulimia nervosa. So at the beginning, they're starting with that over-evaluation of shape, weight, and control, which then leads to your strict dieting, those dieting rules that Deanne talked about. And then that going one of two ways, either leading to a significantly low weight, which of course reinforces that what they're doing is working, or otherwise going for binge eating, where if someone is restricted for so long that they can't maintain that, that ends up in a really big binge where they're eating a lot more food than would normally be eaten. And then that becomes a perpetuating cycle where it's associated with a lot of feelings of guilt and shame for not being able to maintain that strict diet, and therefore leading to those compensatory behaviours we see in bulimia, where people might be purging, misusing laxatives, excessive exercise, and then how that all just goes back and reinforces that over-evaluation of shape, weight, and control. Off to the side there as well is just the events and associated mood changes. So it might be for someone with bulimia that something as what could seem quite as simple as feeling a bit sad, feeling a bit lonely, could also set off that cycle of binge eating or trying to diet, or even events in peer adolescence where it might be a negative comment from a peer, or a fight with a friend might also set off that pattern as well. Some things that I just like to consider when I am looking at treatment for someone with an eating disorder, though, is there are obviously limitations in research, and what is evidence-based treatment might not always be the best way to go. Results rarely generalize to other populations, and especially when we're talking about CAMS, we are looking at really acute and complex presentations, complex family systems, where we do need to consider a lot of aspects before jumping on board with a specific treatment. And of course, there's always a percentage of participants in research that saw no improvement, but of course in clinical practice, we can't just go, well, too bad. We need to look at some other options for them as well. Some of the considerations that I like to have when thinking about the treatment options is whether someone is in a period of starvation syndrome, and that would indicate that they're not quite ready to engage in CBTE, because that takes a lot of cognitive processing and being able to take on board, challenging those thought processes. The complex family structures I've talked about, and just the specific resources required from families just to engage in therapy. They have to give their time, their finances, and their emotional capacity to do this work. Another thing just to note here, and it has been touched on before, is neurodevelopmental diagnoses and comorbid mental health concerns are something that really need to be considered, especially if there's comorbid substance use or alcohol use that's going along with the eating disorder. And with neurodevelopmental diagnoses, there's a lot of research coming out about the association between eating disorders and autism spectrum disorder. And I recently read that anywhere up to 20 to 30% of adults with an eating disorder will sit somewhere on that autism spectrum. So that's something that just needs to be considered when developing that treatment plan as well. With eating disorders as well, I did want to touch on that it is really challenging work. It's so highly emotional. Typically when we see these young people, especially that typical presentation is a very young girl who presents as highly conscientious, very perfectionistic, agreeable, they're polite. You wouldn't think that they would have any bad bone in their body, but in the reaction to the situation of having to eat and gain weight, that eating disorder may cause them to have huge emotional responses, lots of distress, lots of crying, anxiety, avoidance, agitation, aggression, coming back to suicidal thoughts and self-harming behaviours, or even violence towards others. Understandably, this is going to create a lot of contagious distress within the family, and then that distress is going to come to us as the treating team as well. So we're all human and we all have our own emotions. So this highly emotional work is going to generate emotional responses in ourselves, and a lot of ones that are talked about are, anxiety, distress, uncertainty, feeling a sense of inadequacy or failure when things aren't progressing in treatment, or frustration, disgust or criticism, or even sadness that things just aren't improving for a client. The thing to be aware of as well, and one thing I wanted to really emphasize, is the potential of countertransference happening in this population. So countertransference being where our emotional responses then get put back onto the client, and then that can really affect treatment, where a clinician might change their responses, their boundaries. They may inappropriately share information or become overly involved with a client where that countertransference is happening. So just something to be aware of with those emotional reactions. The other thing we wanted to touch on as well was just splitting that can occur. So this is a psychodynamic term that refers to a psychological defense used by people to cope when there's overwhelming emotions. And it's used by seeing someone as either good or bad. So it's really that overly idealized person or completely devalued. Essentially, this process makes it easier for someone to manage strong emotions that they're feeling, which appear to be contradictory at the time. So splitting can occur between anyone in the treating team. It can happen in the family. It can happen from the young person. A lot of the time you might see it happening with mum and dad, where the young person will try and, the eating disorder will tell the young person, to try and get to mum because she's a bit softer. She'll let things slide, and they will idealize mum as being really good. And then they'll devalue dad because he's a bit harsher and a bit more stern on what needs to be eaten. Or it can occur between the treating team where, and especially families that are going to get caught in that contagious distress with their young person, they might feel like someone is doing not as great a job and run to someone else in the team and then ask them to make something change. It's really important to be aware that this isn't intentional, and while it's hard not to take these comments or actions personally, it's a psychological defense and it's not done knowingly. The important thing to do is just to stay calm, take a breath, have a bit of a think before responding. Just show people that you really do care about what's going on and set those healthy boundaries. Healthy boundaries are not always liked, but they are worth it in the long run, trust me. And always working within the treating team to remain on the same page. So the best thing I can say for splitting is if you can work in an MDT approach, do a lot of stakeholder meetings, have constant contact with the other treating team members, you're going to be able to avoid that splitting occurring more often. I won't go too much into this slide, but I did find some research that came out a few years ago. They did some semi-structured interviews with some medical physicians who have treated eating disorder in patients. 4 main themes came out in regards to that treatment. But my bottom line that I took away from this research is universally all of the physicians agreed that they couldn't treat a patient with an eating disorder on their own. It's really important to have those key players involved, your psychologist, your dietitian, your GP, your pediatrician, your psychiatrist, your patient and their family members. They're all very important parts of the treatment process. I pretty much ran through all of that, but MDT approach to eating disorders is vital. Everyone has their role, and it's important to keep everyone on the same page here for various factors. One thing I do want to say is with family members, they should always be included in the care of young people, unless that's otherwise indicated by family law court orders or child protection orders. And that's something that can be looked at in that assessment to begin with. The other thing with young people is we do have various stakeholders, and with CAMS we work really hard to involve our stakeholders as much as possible. So young people, they have to go to school, they have to get that education, and we don't want the eating disorder robbing them of that. So it's really important to keep school stakeholders on board and on the same page, especially if we're looking at meal supervision when they're in that space. Other young people might have NDIS core support workers, DCJ may be involved, or there may be extended family members where a young person might live between various households. It might be grandma, it might be a great auntie, it might be an older cousin or someone that comes into the home, and they should absolutely be included in the treatment process as well. I suppose my last message and what I'd hope to take away from all of this is, because it is such highly emotional work and it comes with a lot of challenges at times, is to look after yourself as the health professional. Again, working in that MDT space and having those stakeholder meetings, staying on the same page is going to be the best way to navigate around splitting or counter-transference as it comes up. Absolutely seeking peer supervision, mentoring, or debriefing. Sometimes you just need to get it off your chest and then you're able to get back on track again. For myself, I use distress tolerance skills. Anything that I teach or lecture about in my sessions with my clients, I use myself, and I highly recommend it. And the bottom line is self-care, self-care, self-care. I suppose for me, despite the challenges that come with eating disorder work, it is absolutely very rewarding. And to see the progress and change that can honestly happen so quickly in some cases, it just makes it all worth it in the end. And some of the greatest working relationships that I've made have been with other professionals that I've shared eating disorder clients with. So it's really fantastic work. But that is all I have. Thank you.
Excellent. Thank you so much to our three presenters this evening, Gemma, Deanne and Dr. Adamson. I am mindful of time, but we do have 3 questions that have come through that we might quickly answer. So the first one is from Christina, and she asked, how often do we need to check for zinc?
I don't know if Deanne wants to answer, but I'll just say that we would normally check it at the beginning of admissions. And if it's normal, I wouldn't necessarily check it again unless I've got difficulties. So really it's a screening thing at the beginning, and it is associated with poor healing, so it's worth checking for. But in my experience, it's not often low unless you've had very long-standing malnutrition.
Excellent. And the next one is from Christina also, and it is, how do we help someone if they only have 1 meal a day? How do we encourage them to eat more than that meal a day?
Do you want me to do that one? So
Go for it.
normally, what I'd usually start to do is some psychoeducation around metabolism, because one of the things that for most of these young people, metabolism matters. They don't really know what metabolism is often, but everyone knows the word metabolism. So often I'll talk about, for a really healthy functioning body, you actually need to fuel it fairly regularly. And I use the analogy of petrol in a car. You know, we're in Tamworth. I'm presenting from Tamworth, so can't drive to Muswellbrook, can't drive to Newcastle with a quarter of a tank of petrol. So how do they expect their body to actually function? And often start working on that very slow, small, regular steps after you've done that education. You'll often find that that car analogy works quite well. And with young people, I often talk about the fact that they're a bit like a Lamborghini. So me as an adult's a Toyota Corolla. They're a Lamborghini, and they actually need a much higher quality fuel. And so you can't get quality fuel if you don't do it regularly. So I often find that's a really nice way to explain it, and they seem to respond fairly well to that.
Excellent. And the last is a comment that we've got from Lorraine, but you might also want to comment, is with those very high mortality rates, I really hope that the government contributes more funding to mental health in this area and staff recruitment.
Do you want to go, Julie?
Yeah, that is a really good comment, and I think it's really only been in the last, I mean, I've been working in the area for 20 years, and Mel Hart, who is our area, and people like Mel and Deanne have been working even longer probably. I think it's really only in the last 5 to 10 years that we've seen significantly improved funding. So it's still got a long way to go, a really long way to go, but it's improved significantly, and there's been a huge amount of advocacy by some of the key bodies, people like those that are working with Inside Out, NEDIC, and the other key services that have been looking after young people for a really long time. We've recently got some more funding in the Hunter. It's not huge amounts of funding, but certainly in the last 5 to 10 years there's been significant improvements. There's still plenty of room to go for all of mental health, I guess, including eating disorders.
I think one of the biggest wins we've had, Bud, is that it's now core business for New South Wales Health. So as a rural dietitian, it's always been very unusual that I worked in eating disorders. My sole caseload is eating disorders. That's all I do. And I was considered a bit unusual, whereas now it's considered core business for anyone that works for New South Wales Health. So that's, for me, probably the most exciting change, because it was always very difficult to, you know, particularly for people living rurally or more remotely, to get access to treatment. And so that's changing, which is really good. And technology is helping with that as well. But we've also now got things like day programs and building within New South Wales. Every state will now have a residential program as well, and that's just a very, very recent initiative that the federal government's announced. So it's slowly improving.
Excellent. One more has come through, and then if there are any other questions, we will we can put them in the chat box and we will get them to be answered electronically. And the next one is there any role for speech path in older adolescents with is it ARFID, I'm sorry about that, related to sensory issues?
There definitely can be. There's often a role for speech pathology, but also occupational therapy as well can be, because particularly around that sensory experience type stuff with food. Because with ARFID, there's sort of three groups of people that tend to present with ARFID, and sensory is one of them. Food-related trauma is another one. So I've actually had a number of quite significant ARFID cases over the years where the young person's had a choking episode or a really, really negative experience with the texture. And that's actually sort of been the initial trigger and trauma for the development of the ARFID. And so we've actually worked very closely with speech pathologists in some of those cases. I've actually used modified barium swallows with a couple of young people with severe ARFID to show them that physiologically there's actually nothing wrong, because they're so terrified, they're quite convinced there's a blockage. And so speech pathology be incredibly helpful with that, and re-engaging and sort of being able to chew and experience different textures. So all of allied health can have a role to play, particularly in individual cases. It's just that the three of us on the screen are kind of the traditional treatment team, but there's a role for lots of allied health, including physio as well. Particularly with our inpatients, we often bring physio in quite early as well to try and get people moving and developing their muscles again, and regaining some of that strength that they lose when they're really unwell.
Excellent. Well, thank you very much for coming on tonight. As mentioned, you'll all have an invite to the peer support session, which is coming up on the 26th of October. There's a link in your emails at the moment. If you have any other questions, please put them through and we'll have them answered. And a reminder, if you could please complete the evaluation, that would be fantastic. But other than that, thank you so much for coming along this evening, and we'll see you in the future. Thank you. Bye.